Fetal alcohol syndrome is a disorder that affects all of us, and today we will discuss some of the important aspects of this disorder. At the end of today's presentation, you'll be able to understand the distinctions between fetal alcohol spectrum disorder, fetal alcohol syndrome, alcohol-related neurodevelopmental disorder. You'll be able to understand and set forth the criteria that are important for these conditions, and you'll understand the importance of early identification of this condition that impacts our entire society. Fetal alcohol spectrum disorder refers to the breadth of conditions that are associated with prenatal exposures to alcohol. Babies who are exposed frequently display growth deficits and developmental disabilities, and as they get older, learning difficulties and social disabilities, and we attribute all of these to the human teratogen that's called alcohol. Fetal alcohol syndrome is common. Here on this panel, we see that Down syndrome, which is a disorder of chromosomal development, occurs in about 1 in 800 babies born. Cleft lip and palate, which is a major birth disability, occurs almost as frequently. Spina bifida also occurs very commonly. And fetal alcohol syndrome, in contrast to these conditions that are associated with intrinsic disabilities in the developing baby, fetal alcohol syndrome is caused by a hostile environment to the developing fetus. It's important to recognize, too, that while we say that the overall prevalence of fetal alcohol syndrome is about 1 per 1,000, it's important to understand that the spectrum of this condition probably is greater than that, and these data suggest that fetal alcohol syndrome is more common in some populations than others. Fetal alcohol syndrome was recognized about 40 years ago, and the woman here on your left is a woman who is about 40 or 45 years old. She might have been a woman who could have been identified in 1973 when Jones identified this disorder. The baby on the right is a baby who I evaluated about 2 weeks ago. And so while despite the recognition of this condition, despite our understanding of its pathogenesis, despite our understanding of it in the medical context, in the social context, in the biomedical context, it seems that the message about the devastating effects of alcohol on the developing baby are still not reaching the general population. Now, alcohol is a teratogen. And a teratogen is an agent that affects the developing fetus, whether it's a physical agent, an infectious disease agent, a pharmacological agent that acts during the pregnancy of the woman to cause differences in the developing baby. And with those birth disabilities, then there are functional consequences. So alcohol is a teratogen. Alcohol as a teratogen is an agent that acts during the pregnancy, so that a woman must be drinking alcohol during pregnancy for us to consider fetal alcohol spectrum disorder. Alcohol adversely affects the developing baby in terms of growth, so that babies who have fetal alcohol syndrome can be identified at birth because of growth deficits. And then it affects structure, and we call the structural differences that have been associated with prenatal exposure to alcohol to fetal alcohol syndrome. And probably most importantly, and most chronically, are the developmental disabilities that are observed in children who have been exposed to alcohol while they were babies. So it says that, so the panel says that alcohol slows mitosis or cell division. It impacts the mitochondria, which are part of the energy apparatus of the developing fetus. It's important to understand that alcohol does not cause gene mutation, so that women who abstain from alcohol are not at risk of having babies who have this disorder. Alcohol, of course, does affect gene expression, which is a little bit different, but we'll talk about that as we go through the talk. You know, fetal alcohol syndrome, as I said earlier, was recognized in the medical context about 40 years ago. But in fact, alcohol abuse has never been considered a positive thing. Here in the scriptures, it talks about the conception of Samson, and everybody knows about Samson. He was a strong man. Here it says in the scriptures, the angel of the Lord appeared to Samson's mother-to-be and said, "Now therefore beware, I pray thee, drink not wine or strong drink." Now this isn't about recognizing or preventing fetal alcohol syndrome, but rather talking about the importance of a woman's behavior during pregnancy, because a baby is precious. Here is a panel from a cartoonist. This might be the 18th century equivalent of a Doonesbury cartoon, and probably you remember that the Doonesbury cartoons were about social commentary. And this is a woodcutting, an oil rather, of William Hogarth, and this is called Gin Lane. And this depicts the consequences of alcohol abuse in London in the 18th century. And so you can see in the center of the panel a woman who's not attending to her baby, and her baby is falling over the railing there. This would be the equivalent of not putting your baby in a car seat. Then you can see that there are men who are pawning their wares, who are trading the consequences of their livelihoods just for alcohol. And then you can see toward the back of the panel how buildings are falling apart. And we think about the disruptive effects of alcohol on our society. And then this panel displays a baby who appeared in a textbook that I used when I was a medical student. The textbook is called Congenital Malformations. It was written by a great embryologist named Joseph Warkany. And Warkany published this book called Congenital Malformations. There was only one publication. It was published in 1971. And this baby's picture appears in the chapter on growth retardation. And you can see that this is a baby who has a small head and has increased neurological tone. And then if you look under the baby's nose, you'll see that the baby has that smooth philtrum and thin upper lip that we recognize as being associated with fetal alcohol syndrome. And the important thing about this panel is that Warkany's book was published in 1971, 2 years before the medical recognition of this disorder. Now it's important to note too that Jones and colleagues reported on the pattern of malformation of babies born to chronic alcoholics who continued to drink during pregnancy in 1973. But in 1968, Lemoine, who had been a French investigator, published a paper on about 100 children who had been born to women who were alcoholic. But that paper was largely overlooked, largely because the paper was published in French. At any rate, in 1973, Jones and colleagues reported on a series of babies children who had been exposed to alcohol before they were born. It's a very interesting story, and I won't take the time to develop the entire story here, but recognize that this disorder was recognized clinically in an outpatient department in a Department of Pediatrics at the University of Washington in Seattle. And these are babies who had been ascertained because they were born to women who were chronic alcoholics who continued to drink. These are babies who likely were in foster care. These are babies who likely were on the wrong side of the social service system. And Jones recognized that these were babies who displayed growth deficiency, that these are children who had heads that were smaller than usual. These are children who had developmental disabilities and academic underachievement. And then from a physical point of view, the children looked different. Their eyes were smaller than average. There were differences in the upper lip and the philtral columns that lie underneath the nose. And there were differences in the hand creases. And the hand creases, you need to understand, are a reflection of fetal movement. We talked about spina bifida as a birth disability that is engendered about 21 days after the baby is conceived. That cleft lip and palate is a disability that is engendered at about 35 days after a baby is conceived. Well, the developing embryo starts to move its hand at about 56 days. And having differences of those palmar creases reflects differences in movement. And most of you know that movement depends on the integrity of the developing nervous system. And so Jones's observations about children who had small heads and developmental disabilities and small eyes and differences in the hand raised the concern that this was a disorder of neurological or neural crest cell development. And in fact, what Jones and Smith recognized in 1973 was that they had recognized, yes, a new developmental syndrome, but its pathogenesis was related to alterations in the developing nervous system. And then most importantly, they recognized that these babies had been to women who had an alcohol abuse problem, who for whatever reason could not stop drinking during their pregnancies, and their babies are harmed as a result. This is a picture of a little guy that I took care of when I was a resident, and you can see that he has clear evidence that he looks different. His eyes are smaller than average. He has that smooth philtrum and thin upper lip that we associate with fetal alcohol syndrome. But he was a baby that was admitted to the hospital because of failure to thrive. And in fact, what we learned while we evaluated and treated this baby in the hospital was his failure to thrive was related to poor state regulation, that the baby was so disorganized in terms of movement and activity and awareness that he couldn't concentrate on a matter so simple as feeding from a bottle. This also is a little boy that I evaluated years ago. He was admitted to hospital because his mother was a heavy smoker. And the house officers called me to ask to see the baby, largely because of the concern about the toxicity of heavy tobacco smoke on the developing baby. But most of you know that heavy tobacco smoke doesn't cause a small head. It doesn't cause a smooth philtral column, and it doesn't cause a thin upper lip. And this is a little boy who had fetal alcohol syndrome. I monitored him over time, and here at age 12 years old, he experiences academic underachievement. He had behavioral issues. He would be what we would say when we were growing up. He was the class clown. He was the little boy who was the one who would always be caught doing something that his teacher would not want him to do. I mean, if she would step outside the room, he would be the first boy up, and he'd be running around the room or tickling his classmates or whatever it was. And yet, when his teacher would re-enter the room, he would persist in his behavior. And so he always experienced these behavioral problems. And if you look at him, you see that his small head persists, the smooth philtral columns under his nose persist, and his thin upper lip persists. What's remarkable about this little boy at age 5 is that he had a sister who was younger, and she was more severely affected. But more importantly here than recognizing that these were two children in the same family who had fetal alcohol syndrome, who were born to a mother who had chronic alcohol abuse problems and who continued to drink during pregnancy, is an indictment against us, because we missed an opportunity to intervene with this mother and her alcohol abuse problem. Fetal alcohol syndrome has been observed throughout the world wherever women abuse alcohol during pregnancy, and this is a photo of a little girl who I evaluated in South Africa. At age 8 years old, her head circumference is the size of a 1-year-old, and she has the physical findings that all of us would associate with fetal alcohol syndrome. These are two boys that I examined when I was in Russia, and here we can see these two boys who have that appearance of fetal alcohol syndrome, with the eyes that are small, that appear to be widely spaced, with the smooth philtrum and the thin upper lip, and that generally engaging appearance. But again, the morbidity associated with this disorder is related to academic underachievement and behavioral and adaptive health issues. So fetal alcohol spectrum disorder then is that breadth of disorders that we talked about in terms of structural differences and behavioral differences that we can recognize from a medical context. Some children, those that Jones recognized in 1973, were probably among the most severely affected children that we might encounter today in 2016. In 2005, I'm sorry, it was in 1997, I think it was, that the Institute of Medicine was convened and recognized and discussed and delineated the spectrum of fetal alcohol spectrum disorder to include not only the severely affected children, but also more mildly affected children. And those children were referred to as having mild or partial fetal alcohol syndrome. And as I've repeatedly said, that the most morbid manifestation of this condition relates to the neurodevelopmental issues that are associated with children who have been exposed to heavy amounts of alcohol. Now, the pathogenesis of fetal alcohol syndrome is not fully known, particularly at the molecular mechanism level, rather. That we know that alcohol affects growth factors, it affects cell adhesion, it affects the way that alcohol is in fact metabolized in the liver, and we talk about these alcohol metabolism polymorphisms. Kathy Sulik, who's a colleague of mine, described in 1983 that alcohol affects neural crest cell migration. And then Algren and et al. About 10 years ago recognized that alcohol downregulates a gene that is essential for normal morphogenesis of the developing nervous system, this gene called sonic hedgehog. So as it relates to sonic hedgehog expression, it's important to understand that sonic hedgehog is a protein that is synthesized in one cell that then sits on the membrane of a neighboring cell and then orchestrates intracellular signaling such that signaling pathways are affected and then morphogenesis occurs. And it's described here in this cartoon. But the consequences of sonic hedgehog expression or underexpression relate to a disability called holoprosencephaly, in which the central features of the face don't develop properly. Some affected children have clefts of the lip, but in fetal alcohol spectrum disorder, one sees that there are deficiencies of the middle part of the face, so that one sees oftentimes a depressed nasal bridge. But more importantly, one sees underdevelopment of the prolabium, which is the structure from which our lip is formed, and that the prolabium is underdeveloped such that the filtral columns then are underdeveloped. And then the upper lip is thin as a consequence of that. This is a baby who has that holoprosencephaly phenotype due to a mutation in the sonic hedgehog gene. And this is a baby who has fetal alcohol syndrome. If you'll notice where the arrow is, it points to the area up under our lips where there is a membrane that hides behind the upper lip. And that membrane that we can all touch and feel with our tongues represents the most forward development of the brain into a left half and a right half. And so you can see here in this picture of a baby who has fetal alcohol syndrome that area is underdeveloped. We talk about that smooth philtrum and thin upper lip in fetal alcohol syndrome, and like to recognize Susan Astley, who has done computer-generated work and correlated computer work with photographs, and has developed a Likert scale in which we can recognize the smoothness of the philtrum. Here's a panel from one of some of Susan's work, and the panel rank 3, the panel right there in the middle, represents the average lip philtrum contour. The panel at the upper lip, at the top rather, panel number 5 represents 2 standard deviations away from the mean, that smoothness of the filtral columns and thin upper lip that we observe in fetal alcohol syndrome, for example, and so forth. So that when we think about fetal alcohol syndrome in terms of its developmental pathogenesis, we think about alcohol exposure, how it affects the developing brain, how that brain can be associated with developmental disabilities, that there are structural defects that we can recognize in a medical context as fetal alcohol syndrome, but then many more children are exposed to alcohol who have essentially normal physical findings and yet don't achieve their intellectual abilities as one would expect. We've talked about the work of Hoyme and colleagues from 2005. I think the work will be published soon, an update of this paper, in which Hoyme and colleagues operationalized the work of the Institute of Medicine and talked about the diagnosis of fetal alcohol syndrome in terms of recognizing the 3 essential facial manifestations, that these babies have growth deficiency, that there are neurological differences, and then the history of maternal drinking. In partial fetal alcohol syndrome, and I suspect that most of the audience today experiences partial fetal alcohol syndrome, largely because we have seen an improvement in maternal care and prenatal care and better nutrition amongst mothers. But women who are healthy but who drink alcohol excessively during pregnancy are still at risk of having a baby with milder features of fetal alcohol syndrome. But the developmental issues, as I'll show you later, are really not much difference in respect to the phenotype. So that when we think about the fetal alcohol syndrome, then the primary manifestation is the face. So that we expect to see either short palpebral fissures or a smooth philtrum or thin upper lip, at least two of those manifestations. We talk about growth deficiency as being less than the 10th centile, which is about 1.5 standard deviations below the mean. And neurological dysfunction, such as a somewhat small head or academic underachievement, and then that history of alcohol abuse. The facial manifestations, again, based on our physical examination, has to do with measuring the palpebral fissures, and then recognizing the differences in the upper lip and the philtral columns. And we use the work of Daschle et al. With her lip philtrum guide. I would comment that the lip philtrum guide now is in the public domain, so that that's an opportunity, I think, for those who are interested in working and diagnosing and developing programs can obtain this information. We've talked about the smooth philtrum and thin upper lip associated with fetal alcohol syndrome, so I won't belabor that point here. Growth deficiency is variable. Certainly children who have failure to thrive, that would be meet criteria for growth deficiency. Children who are short, children who are underweight, those criteria. The developmental disorder largely has come from two observations, one on the matter of measuring the head circumference, and then more recently the contributions from the neuropsychological and the neurobehavioral domains, in which we are starting to recognize and being better able to quantitate the neurobehavioral phenotype that's associated with this disorder. We know that in terms of structure, that alcohol affects the prefrontal cortex, and we know that the prefrontal cortex is involved in learning, that the hippocampus, for example, is involved in memory and recall, that the corpus callosum is important and integral in terms of visual integration, and so forth. So that when we think about fetal alcohol syndrome in terms of its developmental manifestations, we're really thinking about differences, structural differences in the brain that then lead to functional differences in the neurobehavioral range. This is work from Anne Streisguth that was published in 1975. And Anne recognized that children who had fetal alcohol syndrome had a diminution in terms of IQ scores. Now, the average IQ score in fetal alcohol syndrome is about 60 or 61. And what that suggests is that about 50% of children who have fetal alcohol syndrome will have IQ scores that are in the normal range. So that IQ scoring is a rather crude indication of fetal alcohol syndrome. We see issues that are involved in structure. These are some data from Sarah Matson and Ed Riley, who have done some wonderful work in terms of computer generation in the brain on imaging. It's important to recognize, however, that this work is done in the research context, and issues such as hypoplasia of the prefrontal cortex and so forth have been generated in that research context. So that a child who has fetal alcohol syndrome and has a normal head circumference but academic underachievement may not be the child that would be subjected to imaging. On the other hand, if there are differences in terms of brain size, for example, and this is a little girl who has florid fetal alcohol syndrome. You can see that she has short palpebral fissures and a smooth philtrum and a thin upper lip, and she had academic underachievement, and she had a small head. And upon imaging of her head, you can see that right there toward the middle of her corpus callosum, there is that thinning that is associated with this condition. When we think about the neurobehavioral profile in fetal alcohol syndrome and fetal alcohol spectrum disorders, there are a number of issues that come to mind. Parents frequently complain that the children have bad memory, that they can tell you what they learned in school when they come home, but when it's time to do their homework, it's difficult for them to retrieve the information. Sometimes it's difficult for children to pick up on visual cues or social cues. There are problems of speech-language disorders, and then there are these other issues of attention deficits and even in some cases, frank intellectual disability. We already talked about some of the structural differences observed in fetal alcohol syndrome, and these disorders that are, these structural differences have functional consequences. So we talked about the basal ganglia and how they affect movement. Claire Coles and Piedasa Kodituaku have looked at issues of attention, that there have been issues in information processing, visual memory, verbal memory. The Jacobsons at Wayne State University have done remarkable work in terms of what's called eye blink conditioning and the difficulty with which affected individuals have with state regulation. These are data from Sarah Matson and Ed Riley, and in here she has demonstrated that the IQ scores of individuals who have heavy prenatal alcohol exposure are statistically about the same, irrespective of the physical manifestations. And so that while it is important to understand that the children who have fetal alcohol syndrome and growth deficiency and microcephaly and the physical features, it's not unexpected that they have academic difficulties. It's important to understand that a baby who is exposed to alcohol can have intellectual challenges irrespective of the physical findings. Finally, we talk about this neurodevelopmental disorder, and we require that in order to think about the neurodevelopmental disorder in the absence of physical findings, it is imperative that we can document that there was prenatal exposure to large amounts of alcohol. If there is a small head, that helps with the diagnosis, but more often we talk about the neurobehavioral profile. Now, some of you are going to ask, well, is there really a specific neurobehavioral profile that's associated with prenatal exposures to alcohol? Could this be the same as we see in the neurobehavioral profile of Williams syndrome, or could we see this in babies who have been exposed to high dantoins or so forth? So what I'd like to talk about a little bit this session has to do with thinking about that neurodevelopmental profile. In the big scheme of things, we talk about challenges of executive functioning. And in executive functioning, it really has to do with choosing the better of competing interests. And that relates to our attention. It relates to the memories that we've experienced. It has to do with planning and also self-monitoring. Where am I situated in this decision-making process? How will my decisions impact someone else? Is this the opportunity? Is this the time that I should make this decision, or should I defer this decision? And then the matter of impulsivity, and that relates to what's called response inhibition. Well, this is an example of executive dysfunction, and I just showed this with tongue-in-cheek. I frequently am not the first person in the office in the morning, and in fact, I'm often late. And when one is late, one still has to observe the rules. This is my street. There's a little school off to the left, and that's why there's a stop sign in the middle of the road. And if I am late, I still need to stop at that stop sign. I still need to go the speed limit. And probably if I'm late, probably what it says is I should have gotten up early rather than being late and worrying about executive functioning. But the fact of the matter is that as we think about this, we think about this matter of impairment. How is the child doing? How is the child doing in terms of cognition? How is the child doing in terms of regulation? How is the child doing in adaptive functioning? And similarly, for children less than 3, how is the child doing in terms of developmental progress? Neurobehavioral testing, I'll defer to my colleagues in the neuropsychological arena as far as this is concerned, but these are some of the tests that frequently are used when we are evaluating kids or children and even older adults who have the concern about fetal alcohol spectrum disorder. In terms of prenatal exposure, the mother's history is probably the gold standard. If she will acknowledge that she has had an issue, that she drank heavily during her pregnancy, that's a historical feature. If there were maternal health problems related to alcohol abuse, if the mother died of cirrhosis or complications of cirrhosis, that would support that there was prenatal exposure to alcohol. And then if there was collateral history, say that there was a loved one in the family who witnessed the mother's alcohol abuse, then those are the historical features in fetal alcohol syndrome. One of the large questions that we deal with, I think, in this condition has to do with the environment. I've suggested already that prenatal exposure to alcohol represents that hostile environment that is impacted on the developing embryo. And postnatally, there's an environment as well. And the question comes up, are the disabilities associated with prenatal exposure to alcohol, with fetal alcohol spectrum disorders, are those disorders a reflection of the nature of the individual, or could they be impacted by nurturing in a loving home? Well, a number of investigators have addressed this matter. Jones and colleague have done it. Streisguth has done this. Spohr in Germany has looked. We have looked at a group of children in South Africa. We've examined about 100 children over a number of years and have examined these children as early learners, and then we've had the opportunity to examine these subjects as young adults. We've done physical examinations, we've had maternal interviews. In the older patients, we've done functional assessments such as cognition and behavior and so forth. And then we have come together to amass all of our data, to analyze our data, and then develop statistical analysis in terms of those matters which were salient in terms of recognizing the condition in older adults. These are two children. These are non-identical twins that I examined in 1997. And you can see that the little girl who's on the left has a smooth philtrum and a thin upper lip. Both the girls have short palpebral fissures. And we recognized the one little girl on the left as having full-blown fetal alcohol syndrome. The girl on the right is having milder manifestations or partial fetal alcohol syndrome. And here you can understand, this is an example of how genetic differences, because non-identical twins are related as much as our brothers and sisters. And so here we have an intrauterine experiment of nature, if you will, in which two babies who have different genetic constitutions, who are exposed to similar amounts of alcohol, have differing outcomes. I examined these children as they were young adults in 2009. You can see that there's a persistence of the smooth philtrum and the thin upper lip in the older sister on the left, and that the sister on the right seems to be somewhat more mildly affected. Sadly, both of these girls experienced academic underachievement, left school prematurely, and each of them were victimized and became pregnant. Our data showed that growth deficiency, mild microcephaly, short palpebral fissures, and smooth philtrum reached statistical significance at when we examined the children at birth, in first grade, and as they were older, and this was in comparison with controls, and that with older children, that the jaw became heavier as well. And so here we have a man who has fetal alcohol syndrome. He has short stature. Obesity is common in these children, as evidenced by work of Jones and al. And Streisguth and others. The microcephaly persists, the smooth philtrum and thin upper lip. Streiskuth has talked about secondary disabilities, that these are the consequences of the intellectual disabilities that were observed in children when they were younger. And she talks about inappropriate sexual behavior, that affected women may be involved in relationships that are not appropriate for their age and stage, that affected men may have difficulties with impulsivity in terms of sexual behavior. That generally speaking, we talk about the difficulty in staying out of harm's way, that individuals, whether it's drinking or other issues of mind-altering drugs, the fact of the matter is that people who have fetal alcohol syndrome more often are apprehended than people who don't have this disorder. Certainly having impulsivity and academic underachievement makes it difficult to earn an independent living. And so that many of these individuals as adults are dependent upon the human services system. We talked about the matter of underemployment. Behavioral health issues such as depression is very common. We talked about or inferred a disrupted school experience largely because of academic underachievement and this matter of difficulty in staying out of harm's way. Now that it's important to understand, and this is the call for medical champions actually, because the fact of the matter is that we can impact the child who has fetal alcohol syndrome. We know that alcohol is an environmental agent that damages the baby. But if we can impact the environment postnatally, that we can bring about a change in the lives of affected people. And that's the call today. That's the clarion call. Just as we said that we recognized this disorder 40 years ago, it's really frustrating to recognize this condition even today. It's important to understand that a diagnosis of fetal alcohol syndrome is more effective than a diagnosis of fetal alcohol effects or mild ADHD or some of those kinds of things. Sometimes it's important for us as providers to label, because it's that label that allows for service provision. And it's that label that allows for early intervention that makes a difference in the outcome. This is a disorder that is important to be diagnosed early on, before a child even begins school, because that improves outcome. We can organize, we can array the kinds of academic supports that are important for improving the outcomes of affecting individuals. Of course, if a child is so severely affected that he qualifies or she qualifies for developmental disability services, that's important. It's important too to understand that children who are raised in nurturing environments tend to fare much better than children in disruptive environments. You know, there's a proverb that says, if you train a child up in the way he should go, when he's old, he won't depart from it. And with just attribution to my mother, rest her soul. You know, for my mother, it was train the child, and it was respect your elders, and don't talk with your mouth full, and brush your teeth before you go to bed. That's training up the child. And then recognizing the way is important. I can remember when I was in second grade, my teacher looked at me and said, "You look like you're going to be a doctor when you grow up." And that impacted me the rest of my life. But you know, sometimes you can look at a child and say, you know, you have some creative tendencies, or you have some tendencies. I can see that you're going to be an architect when you grow up. I can see that you like to be outside. I think you're going to be involved in landscaping when you grow up. It's important to recognize a person's way, and that's a way of improving that person's outcome. Well, finally, it's important to recognize that fetal alcohol syndrome is a medical diagnosis. And so here in this panel, we have three photographs of three children who have developmental disabilities. The little girl in the red has a disorder called Williams syndrome, which is caused by a mutation in a gene in chromosome 7. The little girl on the right has a disorder called the velocardiofacial syndrome. It's a genetic disorder that's associated with missing gene material on chromosome 22. And the little boy in the middle has fetal alcohol syndrome. You can see that each of these children has a smooth philtrum and a thin upper lip. But it's that little boy in the middle who has his differences not due to a genetic problem, not due to something that's intrinsic to him, but rather he has disabilities that have been engendered because of a hostile intrauterine environment. Well, it's important to understand that fetal alcohol spectrum disorder is caused by exposure to alcohol. That avoidance of this teratogen during pregnancy is a means of improving outcomes in pregnancy. That fetal alcohol syndrome and partial fetal alcohol syndrome are medically recognizable disorders. They are recognizable patterns of malformation. And that we can diagnose these children. We can diagnose the children before they even enter first grade. But fetal alcohol spectrum disorder recognition is a clinical exercise. There is no laboratory test that is currently available that identifies FAS. And so this is a disorder that's associated with being at the bedside. It's about being in relationship with our clients. And then it's important to understand that the neurodevelopmental issues that are associated with this disorder are chronic and that they are lifelong. So that for those of us who take care of children, we can recognize the disorder, we can advocate for school services and those kinds of things. But it's important to understand that children do not outgrow their conditions. They outgrow their pediatricians. And this is a clarion call for those of us to think about the long-term consequences of this disorder, because it's an ongoing challenge. It's an ongoing challenge for human services provision. And lastly, the hope is that new technology will allow us to recognize this condition in underserved populations. There are only so many medical schools in this country. And in developing countries, there are precious few who can diagnose fetal alcohol spectrum disorder. And so the hope is that there will be opportunities to develop paradigms, whether they are computer paradigms or imaging paradigms or biochemical paradigms, that will allow us to recognize the child who is at risk and to be able to impact the life of that child. This is a clarion call for all of us who care about children, who care about our future. I wish you the best, and thank you for the opportunity to have spoken with you today.